Nikita, Senior Resident in the Department of Radiology, AIIMS Bibinagar. I'm going to present an interesting case of a 41-year-old male who presented with the complaints of inability to extend fingers of the right hand since 1 week. He complained of pain and restriction of movement, and he was referred from the Department of Orthopedics in view of posterior interosseous nerve compression. So we performed X-ray of the right elbow, ultrasound of the right elbow, MRI and ultrasound guided aspiration of the cyst, of which we are going to talk about in the next slides. So this was an X-ray elbow. Here basically we wanted to rule out any fracture or dislocation, and we can see that the cortex is intact and there is no evidence of any fracture. And also in the lateral view we can see there is no evidence of any dislocation or any fat pad sign. So in ultrasound, we can see a well-defined cystic lesion which is along the head of the radius and within the muscle or intramuscular plane. This is the muscle of supinator, and here we can see few internal septations which are incomplete, and we can also see there is joint space communication, and this is our posterior interosseous nerve, and which is seen abutting the lesion. These are the T1 and T2 sections of MRI, and here in the sagittal planes we can see there is a T1 hypo and T2 hyperintense lesion within the belly of the supinator muscle, and which was seen communicating with the joint space, and few incomplete internal septations were seen. This is the posterior interosseous nerve which is seen abutting the cyst within the muscle. So with this, we could come to a differential diagnosis of either an intramuscular ganglion cyst or a synovial cyst, or a distended bursa or traumatic collection. So we can exclude distended bursa because we can see that the cyst was intramuscular and also there was no trauma, so we can exclude the distended bursa and traumatic collection. Imaging wise, rarely we could differentiate the difference between the ganglion cyst and synovial cyst. So, coming to literature review, a posterior interosseous nerve is continuation of the deep branch of radial nerve after it penetrates the supinator muscle. Then it runs in the facial planes between the superficial and deep extensor muscles and eventually reaches the interosseous membrane. It supplies motor innervation to extensor compartment of the forearm and finally provides sensory fibers to dorsal aspect of the wrist joint. So here we could see the image where the radial nerve from the arm at the elbow joint is divided into a posterior interosseous nerve and superficial radial nerve, and it is seen entering into the supinator muscle. So what are the sites of compression? So for the first one is, and the most common one, is the arcade of Frost. So it is the most superficial layer of the supinator muscle, and here mostly the compression of the posterior interosseous nerve occurs. Other than that, the distal edge of supinator, the fibrous band anterior to the radiocapitellar joint, and the leash of Henry, which is the radial recurrent artery and its venae comitants, which can compress over the posterior interosseous nerve, and the other one is the medioproximal edge of the extensor carpi radialis brevis, which we can see in this image. So how can it get compressed? Either because of trauma or any microtrauma or any space occupying lesion like a cyst in our case, or because of inflammation of the nerve. Next, coming to synovial cyst. So synovial cyst is a continuation or herniation of the synovial membrane through the capsule of a joint filled by synovial fluid, which may or may not keep a communication with the joint. They are thought to serve as drainage reservoirs for the excessive joint effusion in the setting of any arthropathy escaping from its regular location through a one-way valve mechanism into the area of least resistance. Occasionally, such as in the hip and knee, a pre-existing bursa may develop communication with the joint and act exactly the same way, becoming enlarged. So this is the reason why synovial cyst and bursal enlargement can be used interchangeably in the literature. The wall consists of a fibrous tissue which is lined by continuous layer of true synovial cells, and hence it is considered to be true cyst. A ganglion cyst, contrary to a synovial cyst, lacks a synovial cell lining and constituted by a dense collagenous capsule surrounding a mucopolysaccharide-rich gelatinous fluid similar to that of synovial cyst but at a higher concentration, and they may arise from the joint capsule, ligaments, the tendon sheath, the bursa or the subchondral bone, being generally classified as juxta-articular, intra-articular or periosteal. These are the false cysts. So there is a synovial herniation hypothesis in which we can see that there is a synovial cyst. This lesion is originating from herniation of the synovial membrane through the joint capsule, which consists of true synovial cells. Now these are the ganglion cysts. So during the process of the degeneration, there is going to be increased intracystic pressure. The cellular lining may change, partially disappear and become discontinuous. Ultimately, the original communication with the joint may also get obliterated. So in our case, we followed it up by doing an aspiration from the cyst. Here we can see our needle within the cyst, and after we got an aspirate, we got a gelatinous thick aspirate which was obtained, and it was sent for analysis. And soon after the aspiration, the patient felt decreased pain, and he could feel better range of motion. So these are my references. Thank you.